Is blood in the urine always a kid? Okay, this is your differential diagnosis list for proteinuria. I want to point out, after you've ruled out the acute stuff, like a urinary tract infection or certain medications, don't be afraid to pull the trigger to nephrology. And hopefully, I hope you picked up on this in my lectures. I try very hard not to say, oh, just refer. Oh, you see this, just refer. Man, we don't live in an ideal world. You can't always just refer. But this is one of those rare cases where after you ruled out a few things, proteinuria, you really do need nephrology. And the reason being is, number one, it can be significant of a very dangerous underlying etiology. And number two, oftentimes the etiology cannot be known without a tissue biopsy. Notice what you do not see on this list of differential diagnoses. You do not see protein consumption. So we have weightlifters who consume lots of protein or take creatine powder. For most of those patients who are, let's say, specific to creatine users, they're using the creatine within the recommended daily allowance, the guidelines. Well, as long as those patients have functioning normal renal function, they're going to be fine. You're not going to see proteinuria. But if the patient is chugging the whole barrel of creatine or eating so much protein it's ungodly, then yeah, you can see proteinuria. Let's do some definitions here. I'm not going to do all of these, but focal segmental glomerulonephritis, or also known as glomerulosclerosis in this specific case, that's scar tissue forming within the glomeruli. That can be secondary to lupus. You can see it with HIV. You can see it with heroin use. It can be genetic. Minimal change disease, that's toddlers. So let's go to membranoproliferative glomerulonephritis. That is where there's a deposition of antibodies into the glomeruli. And that's going to affect their filtration. That is the main hepatitis C associated nephropathy. But you can also see it caused by lupus, Sjogren's, RA. You can see it with complement deficiency, so there'll be a low C3, a low C4. IgA nephropathy, also known as Berger's disease, BERGER''S. That is more common in kids, but you can see it at any age. That is where there is deposition specifically of IgA into the glomeruli. IgA nephropathy generally follows after an upper respiratory infection, and it follows after only a day or two. So an example is HeLock-Schonlein purpura, HENOCH/SCHONLEIN purpura. It's a skin rash, an arthritis, and abdominal pain that follows an upper respiratory infection only by a day or two. Now that's opposed to another infection that can affect the kidneys, strep. Post-strep glomerulonephritis, and you can see that with strep throat, you can see that with strep cellulitis. That's going to be several weeks after the infection. IgA nephropathy, several days. Diabetic nephropathy. Lupus. It can be solely for lupus. Now, lupus can cause some of the other things we talked about, or just straight up lupus. Amyloidosis. Amyloidosis, the average age of diagnosis is 55 to 60. And it's a disease where protein builds up in the tissue. And if that tissue happens to be the kidney, it's renal amyloidosis. So the patient will have proteinuria and nephrotic syndrome. It can happen in the heart, leading to congestive heart failure. It can happen in the brain, leading to sensory neuropathies. Diagnosis is with a biopsy. You can see it with other infections, but mostly it's going to be HIV. You can see it with syphilis, you can see it with Hep B, you can see it with Hep C. You can see it with metastatic cancers. So whenever you see proteinuria, you want to do a full physical exam. You're checking the lymph nodes. You want to ensure the screening is current, because more often than not, it's coming either from the GI or the lungs. So if it's coming from the lungs, odds are good that patient's going to be a smoker. So you need to make sure the screening is up to date. You want to make sure the colonoscopy is up to date. Lymphoma, check the lymph nodes. You can see hypertensive kidney disease. That manifests as nephrosclerosis, or a stiffening of the renal components. It's secondary to chronic high blood pressure. You can see proteinuria with hemoglobinuria. That's hemolytic anemia, so check the H&H. The patient will be anemic and likely have fatigue and shortness of breath. You can see with rhabdo, so the patient would have an increased creatinine phosphokinase, and there's multiple myeloma again. You can see it with multiple myeloma. So the patient will have normocytic anemia, likely have some bone pain as well. All right, let's go over this algorithm. Most dipsticks will not give us a quantifiable number. It will just say protein yes or protein no. So that's where we're going to start. The patient has proteinuria, positive on the urinalysis. Well, number one, let's rule out some transient things. Fever. Has the patient exercised within the last 24 hours? Is the patient under significant stress? Does the patient have a urinary tract infection? If any of those are positive, we're going to treat the underlying condition, treat the UTI, the fever, what have you, and have the patient come back in a month. But anytime we see proteinuria, we're going to do a full exam. Let's check the lymph nodes. Look for a rash. Listen to the heart and lungs. That will help us potentially narrow down our differential diagnosis list. But our patient feels fine, he's stable. We're going to have him come back in a month, repeat the urinalysis. We get our two samples, they're both positive. They both say proteinuria. Well, now we need to quantify that. So that's where we can have the patient do either a 24-hour urine protein collection, which is 24 hours of collecting the urine in a big jug, or we can just have them do the spot protein creatinine ratio, which is just one urination. It's a whole lot easier for the patient, obviously, to have them do the spot test, but we can do either one. If you have them do the spot protein creatinine ratio, you'll get a number back, and there's a lot of medical websites where you just plug that number into the calculator, and it gives you the equivalent of what the 24-hour would be. And I was going to throw in a bunch of studies, but they all pretty much show the same. It's fine. Both of these tests are equally efficacious. There are a few outlying studies that show the 24-hour collection is better, but most show the spot urine is fine. So we have our patient do the spot urine. What does the number show? Is it greater than 2 grams of protein in the urine a day, or is it less? If it's less than 2 grams of protein a day, then we need to rule out orthostatic proteinuria. The mechanism of action is unknown. It's most common in adolescents and young adults, but it's where the patient has proteinuria when they're standing. And only when they're standing. They have negative proteinuria when they're supine. So we give the patient 2 empty cups. The patient fills the first cup in the morning, meaning they get out of bed, go straight to the bathroom, and fill that cup. And then mid-afternoon, they fill that second cup, and they bring them both back. For a diagnosis of orthostatic proteinuria, the supine sample, the morning sample, must be normal, and the afternoon sample must have protein in it. So it's not like the supine sample has less protein than the afternoon, no. It's the supine sample, the morning sample, has 0 protein, and the standing sitting sample, which is the afternoon sample, has protein. That is orthostatic proteinuria. Your job is done. It's a benign finding. We don't have to do anything. No further workup. But let's say on that quantifiable protein spot that we did, the spot check, the patient had greater than 2 grams. Or the patient has less than 2 grams, but all 4 samples, meaning the initial, the repeat a month later, and the 2 that we had them do for orthostatic, all 4 show protein. Well, you have to work that up further for underlying etiology. We have a few things we need to grab. Number 1, a serum complete blood count, because we need to evaluate for anemia. Next, a comprehensive metabolic panel, ideally fasting, because you want to evaluate the liver enzymes, the glucose, the calcium, and the creatinine. And then we'll want to do further testing on a case-by-case basis. So if the creatinine is elevated and the patient has that proteinuria, it's likely coming from a renal source. We'll need to get nephrology involved. Let's say the patient has a low hemoglobin, low hematocrit. Well, then you would need to find out what kind of anemia. If it's normocytic, normochromic anemia, and the patient has proteinuria, that should ring the bell for multiple myeloma. We would do a protein electrophoresis. For the same reason, we want to check the calcium, because it can be elevated with multiple myeloma. Let's say the liver enzymes are elevated. That should kind of ring your bell. Hey, this might be hepatitis B or hepatitis C manifesting within the kidneys. So you see, there's lots of different ways we can go with proteinuria, and it's a case by case. But by doing these complement labs, you can really get a great idea of what's going on. Other things you might want to consider. Has the patient had a strep throat within the last month? Now that would generally be untreated. We would want to consider autoimmune manifestations such as rheumatoid arthritis and lupus. So consider checking an ANA, which is a serum test. Ask the patient, do they have joint pain? Are they excessively fatigued? We might want to do an autoimmune workup. That's a whole different lecture. So please don't get frustrated with some of these labs. It will all come full circle. We also want to make sure the patient's screening is up to date. Is the patient current with their colonoscopy? If they're a smoker and they fit the criteria, have they had a low-dose CT scan, screening for lung cancer? Is their mammogram up to date? Consider STDs like syphilis and HIV. All this stuff can manifest through the kidneys. So the take-home point here, rule out the transient stuff, repeat it in a month, then get the quantifiable number. If it's less than 2, rule out orthostatic. If it's greater than 2, or you rule out orthostatic and all 4 show protein, then we do the further workup. Okay, we'll come back to proteinuria in a second, but let's go back to the urinalysis. What are some factors that can falsely affect the urinalysis results? Well, let's start with glucose. Alkaline urine, you can see a false positive with multiple myeloma. A UTI can cause alkaline urine. So basically, if you see a UTI and there's other abnormalities on the urinalysis, just treat the UTI and then repeat the urinalysis a month later is pretty much the way to go. Because infections just change the whole game. You can see a false negative glucose on a high specific gravity, so the patient may be dehydrated. If they pound insane amounts of vitamin C. Or if it's improperly stored. So let's say you have an in-house lab, but the lab goes home at 4 o'clock, but you're still there at 5 o'clock. And you check a urinalysis, and it just sits on the shelf overnight. Well, you're going to get false results. If the lab cannot quickly get to the urinalysis, put it in the refrigerator, and then they can check it the next day from the fridge. But if it's left sitting out, you might as well just discard it. It's useless. With bilirubin, you can see a false positive if the patient takes pyridium. That's a medication taken to aid in dysuria. It just helps with the pain. Same with over-the-counter AZO can cause a false positive bilirubin. And you can just kind of read through this, but just remember, with the dipstick, it's not the best test, but it's cheap, readily available, and it's definitely the first thing you want to grab. Pyridium can cause false positive nitrites and leukes, So if the patient has been taking pyridium, like leftover pyridium, because they feel they have a UTI, and you check the urinalysis and it just shows positive, those can be false positives. You may want to get microscopy to actually look for white blood cells. All right, you got a 60-year-old male. He's here to establish care. He retired to the area. He worked for I think he worked for GM, and he retired to Northern Michigan. He has no complaints other than a bit tired. He has some lower back pain. And you have his previous records, but all you have are his most recent ones, which can be frustrating when you don't get more than that, but we'll take what we can get. White blood cell count, kind of on the high end, but still within normal limits. Red blood cell count, low. H&H is low, so he has anemia. It's fairly mild, but still anemia. So then you look at the MCV and the MCHC, those are normal. So he has normocytic anemia. We'll talk more about that in the lab interpretation lecture, but normocytic, normochromic anemia is generally either cancer or the kidneys until proven otherwise. It's not a good anemia to have. Here's his comprehensive metabolic panel. Jump on down there to the blood urea nitrogen. It's borderline low. His creatinine's high, so it makes sense his GFR is low. There's an inverse relationship there. His calcium is borderline high. So is his protein. His albumin is low. And his bilirubin is borderline high. Okay, so not sure why this wasn't worked up. We don't have previous SOAP notes on him. We don't even have previous labs. We just have the most recent labs that were done 6 months before he sees you. So what could be going on? Well, let's start with this elevated creatinine. The other stuff is fairly borderline. He could have acute kidney injury secondary to his NSAID or his ACE inhibitor. So I would want to know, when did he start these meds? He's on his naproxen for his lower back pain. Given the association with the nonsteroidal anti-inflammatories and kidney disease, I would probably have him switch to topical diclofenac. Let's get him on a topical NSAID that should help his back pain and not get systemically absorbed. You could consider switching him from his ACE inhibitor to another antihypertensive. But let's hold off on that right now. Let's switch him off his NSAID and work this up. So these labs were from 6 months ago. We're not going to do anything from 6-month-old labs. So let's repeat these labs, which you do, and I didn't put them in because there was no significant difference. They looked pretty much the same. So now, what is your follow-up lab? Well, he's anemic, his creatinine is high. Let's check a thyroid. Let's just make sure that there's nothing abnormal with his TSH. Also, anytime there's an elevation in creatinine, at least at the onset, you'll want to get a urinalysis with microscopy. So we'll just add on a urinalysis and a microscopy for this guy. All right, proteinuria and elevated serum creatinine. Let's go over the differentials. Now, we would do our full physical exam on this guy, but let's go over the differential list. Minimal change disease. Well, that's seen in toddlers. We can rule that one out. Focal segmental glomerulonephritis. That's diagnosed on renal biopsy, but it can be secondary to lupus, HIV, or heroin use. So we would ask him some questions. He does have some back pain, so we'd ask him if he's having other joint pain, any rashes, family history of autoimmune stuff. What about membranous glomerulonephritis? Well, that can be genetic or secondary to lupus, hepatitis, HIV, syphilis, NSAID use, metastatic tumor. So let's go over all those. Lupus. Well, we kind of addressed that with the last one, but number one sign and symptom is excessive fatigue, followed by joint pain, and then you get the rashes and things. Hepatitis, well, his liver enzymes look pretty good. HIV and syphilis, we would have to ask him some questions about sexual history. And again, drug use. Non-steroidal anti-inflammatory drugs, NSAIDs, well, we got him off as naproxen, we switched him off that. Metastatic tumor, usually it's coming from the lungs. Is he a smoker? If so, does he fit the criteria for a low-dose screening CT scan of the lungs? What about syphilis? This would be presented as either secondary or tertiary syphilis. Bald spot on the head, rash on the palms and the soles. With tertiary, any neurological changes. What about membranal proliferative glomerulonephritis? That would be mostly autoimmune or hepatitis C. Again though, with hepatitis C, his liver enzymes look pretty good. You can also see this due to complement deficiency, so that would be a low C3 and a low C4. Does he have a history of recurrent infections? Next up, we have Berger's disease. That's with IgA specifically. Does he have a rash? Did he have a recent urinary or upper respiratory infection? Probably not. We can rule that one out. This has been going on for at least 6 months. It's not some acute reaction to an upper respiratory infection. Diabetic nephropathy. We can rule that out. His glucose is fine. Lupus, again, we keep coming back to lupus. Amyloidosis. Well, amyloidosis, he's of the age, but the only way to diagnose that is with a tissue biopsy. It can be post-infectious, but again, this has been going on for a while. We're kind of outside of that range, at least for IgA specific. But we could ask him about strep. Within the last year or so, has he had a serious sore throat or skin infection? GI and lung cancers, is he up to date with his screening? Lymphoma, we're going to check his lymph nodes. Hypertensive kidney disease, we can rule that one out. His blood pressure is fine. It has to be significantly and chronically elevated for hypertensive kidney disease. This guy does not fit that. Hemoglobinuria, well, no blood was recorded on the dipstick. We can rule that one out. Myoglobinuria, same thing. What about multiple myeloma? Well, he has normocytic anemia, he has bone pain, he has low albumin, he has borderline elevated calcium. So what's your plan for this guy? What do we do now? You could certainly refer him to nephrology, that would be fine. But let's be sure we know what we're dealing with. So we're going to stop his NSAID, we're going to cautiously continue his ACE inhibitor, we're going to repeat the urinalysis in about 2 to 4 weeks. I'm okay with 2 samples. This guy doesn't really fit the bill for orthostatic proteinuria, plus he has the elevated creatinine. So we don't need to go down that route. Let's just repeat the urinalysis. 2 samples are fine. No exercise within 24 hours though. So we get his repeat urinalysis, he still has protein. What are our add-on labs going to be? Well, given his back pain, we would like to rule out autoimmune disorders. Let's do an autoimmune workup. We could check for his complement factors. We could add on an HIV, RPR for syphilis. We could add on labs for hepatitis B and C, even though his liver enzymes were normal. We're checking the labs